afternoon to all. At the outset, I thank the organizers for giving me the opportunity to speak on application of URS for stone disease in children. Before I delve into my presentation, I would like to thank Shripati sir, who has inspired me to take up stone work in children. The constraints in kids include the smaller size of the male urethra, a narrow vesico-ureteric junction, and narrow ureteric dimensions as compared to those of adults. But recent miniaturization of durable equipment and evolving experience has made this an option in young kids. Recent AUA guidelines suggest URS should be offered to symptomatic kids and those with hydronephrosis with stones less than 20 millimeters. This is the equipment showing the holmium laser. That is a flexible ureteroscope, the 7.5 French tip, 270 degrees angle of deflection at the tip, and a 3.6 French working channel. A couple of guide wires, one hydrophilic, another stiff guide wire with a hydrophilic tip. We keep a range of scopes ready, an 9.8 cystoscope with a 5 French working channel, a 4.5 French semi-rigid ureteroscope with a single working channel, and a 6.5 French ureteroscope with a dual working channel, and a couple of stone removal forceps. The surgeon is seated at the end of the table with the C-arm positioned over the patient, and the monitor is placed at the head end of the table towards the side of the stone. This is the conventional lithoclast, which is powered by oxygen either through a cylinder or through the wall mount. And to the right is the handheld probe, which is powered by the oxygen, and it is used to blast the stone. Going on to the actual process of lithotripsy, mechanical lithotripsy, you first need to place the probe against the center of the stone and hitch it against the ureter. The stone is blasted into small pieces. Currently, it is not advisable to retrieve the pieces because it can cause damage to the VUJ and to the male urethra. It's always better to work around a safety guide wire because suddenly if the vision is lost because of edema and bleeding, the guide wire will be a lifesaver. Currently, mechanical lithotripsy is advised only for lower and mid-ureteric stones. Moving on to RIRS, which is very useful for upper ureteric stones and pelvis and calyceal stones. This is the holmium laser. We start by setting the laser fiber size. Generally, a 230 micrometer laser fiber size is used in kids. Next is setting up the pulse energy and the frequency of the laser, the product of which is the power of the laser in terms of watts. There are two modes available. One is dusting, another one is fragmentation. Once this is set, the laser fiber is ready to use. We start with the process of passing the guide wire and then the access sheath over the guide wire under image intensification all the way to the renal pelvis. The next process is to pass the flexible scope through the access sheath. The access sheath helps in easy passage of the scope, and it also drains the irrigation fluid while the process is happening. This is also under II. This is the process of dusting using high frequency and low energy. We start at any part of the stone that's accessible, and this involves continuous movement of the laser over the surface of the stone without direct contact. It converts the whole stone into a gold dust, which need not be retrieved, and the chances of ureteric damage are much lesser with this technique. Next is the process of fragmentation using lower frequency and high energy. This is a direct contact technique. This fragments the stone into pieces. The stone can get retropulsed into the calyces, and they need to be retrieved. It has got slightly higher chance of ureteric damage in kids. Now the tricks: save the initial II image with the scope position next to the stone. It helps to identify the stone when the vision is lost as a result of bleeding. Push the pelvic stones into a favorable calyx and continue to break the stone. Stay away from the dome of the calyx. Limit utilization of the laser to an hour max to avoid renal damage. Aspirate the bladder or drain the bladder with a Venflon cannula in small kids while you're doing the procedure, particularly when you're not using the access sheath. More than one procedure is indicated for larger stones. Make use of IV Buscopan and long procedures to prevent ureteral spasm. If the vision is lost, restent the ureter and call it a day. The lower calyceal stones are particularly notorious because of the access to the lower calyx through the infundibulum. Both the scope and the laser fiber need to be bent to access and break the stone. At the start of our ureteroscopic practice, it might be a good idea to pre-stent all ureters and walk through the length of ureters to familiarize yourself with anatomy before you venture into the more complex stuff. Thank you very much for your patient listening.
So, sir, what do you advise for lower calicial stones? I mean, do you advise URS routinely or a PCNL or something else?
Yeah, so that's a good question. So lower calyceal stones are always quite difficult, and the decision making again is quite difficult. If I find that the lower calyceal stone is showing some sort of extension into the renal pelvis, then I go ahead with the RIRS. But suppose I think it's very complicated, particularly if the infundibulum is very hard to access, then at the outset I plan for PCNL.
Thank you.
Any questions from the audience?
Flexible scope or the sheath.
Yeah, so for RIRS for flexible, before I use a flexible scope, all the kits are pre-stented. The smallest kit that I have done is 8 months old. So, and another point is to try to get a bigger stent through, at least a 4 French stent, because if you pass a 3 French.
That's right, but smaller baby, that is the smallest sheath is available.
So we don't use the access sheath in small babies. So nowadays, generally, I avoid using the access sheath in most of the patients because I just do it directly. And secondly, for lower calyceal stones, I feel particularly it's useful to avoid the access sheath because it will allow your scope to bend in a much better way.
What is the protocol for dilatation of ureteric opening in case you are not able to stent or pass through that access sheath?
Yeah, so in case you are not able to pass through the ureteric opening, but currently being very honest with you, in my practice that is becoming quite rare. You mean the negotiation of the VUJ, it might be 1 in 10 patients. So in those kids, I pre-stent. For RIRS, all the cases are pre-stented, but for routine lithotripsy, if suppose it's a lower or mid-ureteric stone, I don't pre-stent. If I'm able to access the ureter with my semi-rigid scope, I still go ahead and do it.
And sir, that pre-stenting, that means how many days before the surgery? Actual surgery?
It can be 2 to 3 weeks time. That's all is necessary.
Thank you.
Thank you, Senthil.
Thank you.